Hello, I'm Ajay Kakkar from London, and it's my very great pleasure to be joining this important symposium on issues of thrombosis and COVID-19. These are my disclosures. I shall leave them up for a moment so that you can study them. And what I'd like to talk to you about today are intravascular thrombosis complications and COVID-19, and in particular, the progress we're making with regard to understanding how we should use anticoagulation. Now, what we know, 1 in 4 deaths might be accountable to the problem of intravascular thrombosis. It does represent the leading pathophysiological cause of global mortality. We understand, of course, that thrombosis may manifest itself in different vascular beds, arterial and venous. The commonest cause of cardiovascular death is ischemic heart disease, followed by stroke, and then by venous thromboembolic disease. And what's striking is that these 3 manifestations of thrombosis appear to differing extents to also be seen in patients diagnosed with COVID-19. So what have we learned about the thrombosis problem and COVID-19? Well, of course, we know much more about the disease, about the SARS-CoV-2 virus, and that principally it's recognized as a respiratory syndrome, but with important vascular manifestations. We all know now, as we are here in October of 2020, that COVID-19 represents a global pandemic, and it has had a tremendous and devastating impact globally, both in terms of mortality and the morbidity associated with the condition known as long COVID. Millions of patients have unfortunately lost their lives throughout the world. But recent data in early October from the World Health Organization indicates that probably only 10% of the global population has so far been infected with SARS-CoV-2. So there is an awfully long way for this pandemic still to run. And what we've learned, of course, is that those infected with the virus demonstrate, to a greater or lesser extent, evidence of systemic activation of the coagulation system, and that the manifestation of this activation of coagulation is seen in both large and small vessels, both venous and arterial. We also know that the more pronounced the coagulation activation, the greater the risk for poor clinical outcome. Now, when we look at the pathophysiology of COVID-19, we're able to recognize a number of clear pathophysiological manifestations. We know, of course, that the infection is caused by the SARS-CoV-2 virus, that this results in both a hypercoagulable state, in a pathological process in the endothelium, and in, of course, an excessive immune response, the so-called cytokine storm. We have a far greater understanding now of how these elements come together to manifest themselves in terms of the processes that result in the activation of blood coagulation, the activation of platelets, and the activation of the immune system. And we have a far greater understanding now of how the immune system and the blood coagulation system, always recognized to have been connected to each other in elements of the activation phases, come together now to create very powerful phenotypes in different patients. On the thrombosis side, manifesting as macrothrombosis, or indeed microthrombosis, something which is been termed so-called immune thrombosis. There's a lot more to learn about the pathophysiology of thrombosis in COVID-19. But what we do understand, both in terms of the clinical manifestations as the disease progresses in individuals, what we have seen in terms of autopsy, what we're able to study by way of laboratory hemostasis, and of course the recognized but so far demonstrated retrospectively impact of anticoagulation, is that thrombosis and therefore anticoagulant therapy are critical to the appropriate management of patients with COVID-19. Now, what do we know about anticoagulation? Well, rightly, during this last 9 months, as experience has increased with regard to the use of anticoagulant therapy, a number of series and retrospective studies and analyses have been published. This is one published at the beginning of this year that looks retrospectively at patients with COVID-19, a small number of whom received prophylactic doses of heparin. And you can see that heparin prophylaxis appeared to be associated with a decrease in mortality. Again, if we look at this particular series, a larger number of patients hospitalized with COVID-19, you can see that therapeutic anticoagulation was assessed against no anticoagulation. Again, this is an observational study. The endpoint was survival. And you can see over here that in hospital mortality rates were different in terms of median survival, with median survival being longer for those exposed to therapeutic heparin compared to those without. And then, of course, there's the very large series from the Mount Sinai system. Here, some 4,000 patients managed with COVID-19 admitted to that hospital system were assessed. You can see here that a small number of patients in this series received therapeutic doses of anticoagulation, just under 2,000 prophylactic doses, and some 1,500 no anticoagulant therapy. And it's interesting here to look at the adjusted hazard ratio for death against no anticoagulation for those receiving prophylactic or therapeutic anticoagulation. And you can see also here the rates of reported bleeding. And what's striking, again, from this retrospective analysis, observational of a series of patients, is that prophylactic anticoagulation was associated with 50% reduction in risk for in-hospital mortality, with a rate of major bleeding comparable to those on no anticoagulation. So there is emerging evidence that intervention with anticoagulant therapy can have benefits for patients with COVID-19. And the studies I've just shown you are in hospital patient populations with COVID-19. As a result of these retrospective analyses, a number of very large series of studies looking at either anticoagulation with apixaban compared to aspirin or with unfractionated or low molecular weight heparin. Both trials are currently recruiting, and it will be very interesting to see how these trials provide evidence of the potential benefits prospectively for patients with COVID-19 receiving anticoagulant therapy. We are conducting a global study which will be conducted in countries throughout the world, 10 countries, an open-labeled randomized phase 3 trial of community-based intervention with prophylactic doses of the low molecular weight heparin enoxaparin compared to standard of care in COVID-19 patients. And we wish to determine with investigators in such countries as the United Kingdom, Belgium, India, Russia, Brazil, South Africa, and so on, whether exposure for up to 21 days from the time of diagnosis with symptomatic SARS-CoV-2 infection, so COVID-19 disease, in the community setting compared to no anticoagulation will impact on meaningful clinical outcomes such as hospitalization and mortality. This is an open label, multi-center, multinational study, and some 1,370 patients will be recruited from 30 centers. The endpoints are death, admission to hospital, and the bleeding endpoints will be defined by ISTH criteria for major clinically relevant non-major bleeding. And of course, we will also look at rates of stroke. This study is, as I say, to be conducted not in a single country, but in a number of countries around the world. But what do current guidelines and recommendations from societies tell us about how we should look at patients at the moment? In terms of VTE prophylaxis, you can see a range of societies here are providing now recommendations on intervention, principally with a low molecular weight heparin. The real question for hospitalized patients is whether prophylactic doses of low molecular weight heparin are sufficient, or whether a patient should be offered earlier in the natural history of their hospital course higher doses, potentially twice the prophylactic dose, or indeed full treatment doses of low molecular weight heparin or unfractionated heparin. That's an important question where patients have no evidence of underlying thrombosis. Once patients have established thrombosis, well, then therapeutic doses of anticoagulation are recommended, and certainly there, once again, careful clinical judgment, monitoring and management of patients with established thrombosis remains critical. So in conclusion, what we do know now, after many months of intense evaluation and investigation, is that for COVID-19 patients, there is an important risk for the development of both micro and macrovascular thrombosis. These patients have an important frequency for the development of venous thromboembolic disease, including pulmonary embolism. That in careful evaluation of patients who've been managed in hospital for COVID-19, exposure to anticoagulation is associated, or appears to be associated, with an improvement in prognosis. But how we provide that anticoagulation, the doses to be used in these patients, is a matter for current contemporary randomized controlled trial evaluation. And there is the intriguing question of whether thromboprophylaxis with prophylactic doses of an anticoagulant offered to patients earlier in the natural history of disease, potentially in the community setting, could have an important impact in terms of the progression of the disease, ultimate hospitalization and death. And again, those are questions under evaluation in prospective randomized controlled trials. Thank you very much indeed.